do a little bit more of the health education. It's really important topic. It's one of the cornerstones of nursing. So we're going to look at a couple of different ways to teach patients. Key theories, cognitive learning, behavioral, social, experiential, transformative, and humanistic. We're going to go through those in a little bit more detail. So the cognitive learning is just that individual's internal thought process. How well are they able to maintain that information and understand? Behavioral, we're going to do a lot of positive reinforcement. Even if a patient does something that we deem morally wrong, we are still going to find a way to positively reinforce them. We can do something like the positive reinforcement sandwich, where you take something positive, then you tell them the negative, then you go right back into a positive. We are always going to leave that patient on a high note because it will increase the likelihood of them continuing those desired behaviors. Social and experiential learning. Experiential learning is a lot of what we do in nursing. We do clinical, we do lab. The best way to do experiential learning is to do it somewhere safe where making mistakes is not going to cause issues. That's why we do simulations in later labs. We do the simulations so that you can make mistakes without causing any harm and learn from them. Making those mistakes and real world experiences without the potential for harm are a great way to retain and recall that information. Transformative, we want to change the patient's thought processes. If they don't understand why they should quit smoking when they already have COPD, we need to educate them that they can reduce the severity of the COPD by quitting smoking. And humanistic learning is looking at the person as a whole. We need to know what kind of interest do they have in the topic. Going back to the COPD patient, if they say, there is no way I'm going to quit, I don't care what you say. I will never quit smoking. It makes me happy and it's what I want to do. Nothing you say will make them quit. So we need to find other ways to help them manage their care that include continuing to smoke. We need to document our butts off that we educated them on the risks and benefits of quitting smoking, that they declined, and we need to document every patient contact for education that was touched on. It may annoy the patient, and it doesn't mean you need to go into an entire spiel every time. Just telling the patient, I need to ask this as a part of my care. Are you ready to quit smoking, and are you aware of the repercussions of not? Can really just make a difference as far as your charting goes. If you did not document it, you did not do it. So make sure we're educating constantly, because if that same patient goes on to have lung cancer and decides to sue and say nobody ever told him, your documentation is going to back that up. And you just saying, well, I told him, has no merit. Learning styles. We've got our visual learners. They're the ones who want to see videos, models, look at photos. Auditory learners. They listen. They benefit from recordings like this, podcasts, all that different kind of stuff. Reading and writing. Those are your people that just read the book, take notes, and they learn the information. And then our kinesthetic learners are the ones that are going to benefit the most from hands-on practical applications. In nursing school, we try to do as much as we can to hit all four of those. And it's the same way in patient education. Three domains. We've got the cognitive domain that focuses on your intellectual ability to think and retain knowledge. The affective domain is your emotional response to the information. Are you in a place where you can accept that information? And then the psychomotor domain is all the tactile, sensory, motor actually doing the actions. It's important we encompass all three domains when we're doing education in order to get the best outcomes. So the cognitive domain goes by Bloom's taxonomy. This is how I write exams and how NCLEX writes exams. In the beginning of nursing school, we focus on knowledge comprehension, and about 35% of the exams and fundamentals will be application or higher. When you get to second, third, even fourth semester, the amount of application or higher increases. In my geriatrics and mental health class, which gets taken in third semester, 95% of the test is application or higher. So it's very important that we're not just relying on memorization. and understanding. We need to know how to apply that information. So the knowledge is just simply remembering and recalling. It's like in anatomy and physiology. When they say, "Where is the femur?" you can point to it. Comprehension, the ability to understand and interpret what you're learning. This is when you're looking at anatomy and physiology. Okay, now we know where the femur is, but what's one of the main functions of the femur? We can talk about the storage of calcium. We can talk about um, that it's a long bone, so it's one of the bones that's helping to maintain our shape. All those kinds of things are the comprehension level. Application is applying that learned material in a new or unfamiliar situation. So now we're looking at nursing. If you have a patient with a femur fracture, what does that mean? That patient's going to be immobile. So how does that apply to the rest of their health? Analysis is breaking down that information into its parts. Now we know they're immobile because of that femur fracture. What does that mean? What are we going to need to do about it? Synthesis is taking all that information together and doing it. And we're going to generate that new information. We're going to start, instead of just looking at the immobility, now we're looking at the pressure ulcer risk. We're looking at the DVT risk. We're looking at all the different things that can come about from it. Then evaluation is appraising and critiquing that information. Now we have all that information. What did we do about it and did it work? The affective domain. This is the one that is very, very important that really gets missed a lot. We're really good about looking at how a patient learns, but we're not great at looking about at their readiness to learn. So, are they able to receive that new information? Are they in pain? Are they distracted? We need to know if they're ready to receive the information. Are they actively participating or are they just going, uh-huh, mm-hmm, mm-hmm. We need them to be responding, actively participating in that education. How much do they value the information? With the COPD smoker, he's already got a disease that he was afraid of getting potentially. So, does he value quitting smoking? We need to ask and determine these values in order to be able to educate. Prioritizing. What's the most important thing for the patient? Is the most important thing they want to learn how to remain out of the hospital? Is it how to use their medications appropriately? So, what is their priority for educating? It is important as educators and nurses that we realize that our priorities and the patient's priorities may not be the same, and it's important to focus on what's important to the patient. And then, are they able to change those behaviors consistently? We want to start small. We can't start somebody with an entire change in their lifestyle and expect it to stick. We need to start small, encourage progress, and then once they've mastered one skill, build upon it. Psychomotor domain. This is all your sensory motor skills. We need to watch them do it. The health belief model. This is a lot of what does the patient believe will make them feel healthy? Do they think that their illness is serious? What is going on around them that impacts their health? And how likely are they going to make these changes? Health promotion model. We're going to look at individuals. How old are they? Are they male or female? What is their health status? If we've got a 92-year-old who is very frail, they may not be likely to make as many changes as a 35-year-old who's very healthy but now has a new diagnosis. Behavior specific. We're going to look at cognition. We're going to look at affect. We want to see how the patient is doing. Are there any external situations that are causing them to have more problems? And then what is our outcome we want? And we need to make sure that the patient is on board with the outcome. The trans-theoretical model, we're going to look at stages of change. It's important that we look at this model in order to know where somebody is in the process of changing a behavior. So the pre-contemplation is our smoker with COPD. I'm not changing. Nothing you say is going to make me change. He may forever stay in this stage, or he might go on to the next stage, which is contemplation. Maybe he's like, okay, so I have COPD, but it's not as bad as it could be. Maybe in the next few months I might make a change, but I really need to think things through. Then we go to the preparation. All right, I think I'm ready to quit smoking. What kinds of things do I need to quit smoking? In the action stage, he's actively trying to quit smoking. He's got his nicotine gum or his patches or his Wellbutrin or his Chantix, whatever he's choosing to do, and he is trying to be consistent, but it's been less than 6 months. Maintenance. Now he's made the change and he's consistent with it, and it's been 6 months and he's doing really well. So, those are the stages of change. We have to get through the first few stages in order to get to that action stage. If they do not make it past the pre-contemplation stage, you will never get them to maintenance. Culture is huge when it comes to health education. In some cultures, making eye contact is rude. So if you're educating and you're making eye contact, they are not going to listen to you. In some cultures, they want to hear from specific people. In some cultures, they have low health literacy. Some cultures believe that sickness is caused by heat or cold. So if you're not talking to them in terms that match what they believe about health, you're never going to get through to them. So cultural competence is important in every step of care, and health literacy is important. That is the patient's ability to understand medical information. Average regular literacy, which is just the ability to read in this country, is sixth grade. If we're presenting information with a lot of big medical terminology, they're not going to necessarily understand it. We need to meet them where they are. If because of certain things that have been happening in our government recently, health literacy is on a decline. Patients are not believing truths and facts about medical care. So it's important we assess what they believe to be true and where they are as far as health literacy goes. There are people that believe that fluoride, which is really great for your teeth, makes frogs gay. No matter how many times you tell them it will not make frogs gay because frogs do not reproduce sexually, they may not believe you. So we got to meet them where they are and find out what they believe so we can focus on changing or working within those beliefs to get them to understand what we're trying to do. Healthy People 2030 is pretty much just a set of goals. It doesn't have any guidelines or anything like that. It's just goals that we want to meet. As far as health literacy goes, we want to increase people where we're looking to make sure they understand what they're doing. We want to decrease people who have poor communication with their provider and don't feel like they're being listened to. We want to increase decision making between the providers and the patients. We want to increase the people who say they can understand their medical record, which is why we're shying away from medical terminology and abbreviations like SOB. If you write patient is SOB, they may not recognize that it means short of breath and they're going to wonder why you're calling him a son of a bitch. So it's important that we use plain speaking, plain language when we're talking to patients. We want to explain things clearly. If somebody has limited English proficiency, we want to use appropriate translators. I do not want to come onto a floor and see a nursing student or a brand new nurse using a patient's family member to translate. It is inappropriate and you are very likely to get incorrect information translated to both you and the patient. We are going to use certified interpreters at all times unless the patient puts up a fight about it. And if they do, we are going to document that they were offered a certified interpreter and declined in favor of whoever. We are not going to use Nancy, the nurse down the hall who speaks Spanish but is not medically certified to translate for a patient. We need certified medical interpreters who are there specifically to interpret medical information. Here's to health learning, education level. The lower the literacy, the lower their ability to understand the complex health information. So we need to break it down. Medical jargon, saying things like orthopnea or hemoptysis. A lot of people don't understand that that just means struggling to breathe laying flat or having blood in your sputum. Even if somebody is highly educated, they are not likely to understand medical jargon unless they are in the medical field, so we're not going to use it. Limited English proficiency. That's why we're going to use materials in their preferred language. We're going to get them an interpreter. So we do have strategies that can be helpful. We're going to use universal precautions, assuming everyone struggles with information. We're going to use plain language, limit the content, slow down our teaching. We're not going to shove a bunch of information down somebody's throat at once and say we educated them. We need to start patient education and discharge planning at admission. If we start then and we do small bits of information throughout the entire hospitalization, it's going to be understood better. And if we're discharging someone and we're not 100% sure that they understood the information, we are going to try to get them home care. Home care nursing can come in for 1 month specifically to educate. And we want to make sure they have reliable sources, that they're not using WebMD. Community engagement. Public health nurses are great. They do health education initiatives in the public. Um, Things like Lamaze classes are phenomenal because it utilizes a community. People are making friends. They're working with people who are dealing with the same things they are. And it really helps to make sure we're doing some patient-centered and inclusive teaching. So developing programs. First, we want to see what the community needs. We're going to go into the community and we're going to work with community members. We're going to work with maybe the mayor of the town, find out what the community is dealing with and what they need to learn. Then we're going to figure out some goals. What do we want to achieve while we're teaching? Is there a short-term goal where we want to get everybody with diabetes checking their blood sugars by the end of the week? And then our long-term goal is to prevent diabetes complications. How are we going to deliver it? Are we going to have a big lecture? Are we going to have a bunch of nursing students come in and do some teaching together? Are we looking at little kids? Are we looking at older adults? Are we looking at a very large Nepali population, or are we looking at a very large white population? Because each population is going to have their own general needs. And then we're going to deliver the program and we're going to use plain language and we're going to try to get the audience involved as much as possible. If there's somebody in the community who is in the medical field, maybe have them come up and speak as well. Somebody they know delivering some of the information can really help cement what they need to learn. Then we're going to evaluate. We're going to do the teach back method. We're going to have them teach us what they learned. We're going to see how the educators felt they did, and we're going to assess the program using feedback. We can hand out surveys. We can go back a week later and see how everybody's doing. We always want to be continuously improving our skills. In nursing, you will never be at your apex of your skill. You will always be able to improve and learn, and that's one of the great things about the field is there's always something new you can learn and improve on.